Good morning, ladies and gentlemen. It's a great pleasure to be virtually with you in Egypt. My name is Martin Maresch. I'm vascular and endovascular surgeon with a special interest in managing the venous pathologies. This is a talk about the essential role of the intravascular ultrasound in venous reconstructions. Our specialty went through a lot of changes within the last 15-20 years, and the treatment of the venous disease is one of them. The deep venous thrombosis for many years has been considered as a medical disease, and the surgeon was left aside. But this is about to change. The deep venous thrombosis is a serious medical issue with a life-threatening consequences, and the incidence is on the rise. So we have to be really focused and on alert treating these patients. This is the diagram of a current management of the deep venous thrombosis. After the diagnosis, some patients indicated for IVUS filter, but the majority we start with anticoagulation. And then it's very important to distinguish in between the distal and the proximal or central or iliofemoral disease, since these two groups are treated differently. The proximal disease we treat much more aggressively. The distal disease we can keep the patient on anticoagulation alone. But for the proximal iliofemoral disease, the catheter-directed thrombolysis or pharmacomechanical thrombectomy or their combination is definitely giving a much better result than anticoagulation alone. What we use are the aspiration devices like Aspirex, stent French, very powerful suction device, or the angiojet. The device, which is working on a different principle, but it's very effective as well, and allowing using thrombolysis as well. These are the reason why we treat these patients much more aggressively nowadays, because the anticoagulation for the proximal disease just does not prevent post-thrombotic venous insufficiency or post-thrombotic syndrome. And the morbidity of this complication and consequence is very significant. It can damage the lives, especially of a young and dynamic patient, and we should consider the intervention for the proximal DVT with advanced symptoms and reasonable risk. And we do this because in these cases you can see the immediate relief of the symptoms. Usually the patient improved on table. You decrease the risk of pulmonary embolization, and the most important, you can improve the quality of life in a long term by decreasing the post-thrombotic syndrome. Post-thrombotic syndrome is occurring, according to the literature, in 25 to 75%, but because of the proximal obstruction in the drainage, in my experience, all the patients with proximal blockage experience some kind of symptoms of high venous pressure. This is the data published by Nikos Apropoulos, and as you can see, these are the symptoms. On one side, you can have a patient suffering from some mild edema and the heaviness of the legs, but on the other side, these are the young patients suffering from unhealing venous ulcers, and unless you open up the proximal blockage, they never improve for a long time. So according to the onset of the thrombosis, we can distinguish in between acute, subacute, and the chronic. In acute phase, the thrombectomy and thrombolysis is extremely effective. It's usually about like 6 weeks, but sometimes we intervene even in like later than that, up to like 2 months, let's say. Then there is a subacute, the inflammatory phase, which is not really suitable for the intervention. It's better to keep the patient on anticoagulation and wait till like 6 months to stabilize the thrombus, and then we intervene for a chronic DVT as well by different means, by the venoplasty and the stenting. In chronic cases, the goal is to provide unobstructed venous drainage from the deep femoral vein all the way to the IVC. For these chronic cases, it's supposed to be first line treatment. It's recommended by the biggest societies in all the guidelines, and the surgery nowadays is a bit obsolete only in cases of the failure. Venous stenting is different from arterial. Obviously, it's very important to stent from healthy to the healthy segment, so it sometimes needs a very long stenting. Sizing is extremely important, and as we know, the veins on venography are very dynamic. The IVUS is essential, and we have to say, so far there is no ideal venous stent. And again, the beginning of the venous interventions was copying what we know from the arterial, but unfortunately it doesn't work, and it's from the beginning, because the venography is different. You can see on arteriogram, you can see all the branches, you can see nice flow. The venogram sometimes gives you very bizarre pictures, and it's very difficult to find out the branches. That's why the intravascular ultrasound is supposed to be a mandatory tool for everyone who gets into the venous interventions. It helps with diagnostic, and it can reveal the anatomy invisible on the venogram. It's essential for all measurements and sizing, since to measure the diameter on venography is very difficult. Many pathologies are anterior-posterior compressions, so you can get the false impressions, and it helps also in the management of the complications. We know from the ATTRACT trial that the venogram itself, it's falsely reassuring if you compare it with the IVUS. In the ATTRACT trial itself, the rate of stenting is near 90% after iliofemoral proximal DVT when using the IVUS guidance. And unfortunately, it was not in all the cases in ATTRACT, and this is one of the reasons why the ATTRACT trial outcome was as it was. There was also the video study using comparing the IVUS and the venography, and using for the patient with a proximal disease, and you can see there is a significant difference, 50 versus 80% in lesion identification. There was a big difference in the management of these patients. Even though they used the 3D venography, there was 1/4 of the patients were completely missing their pathologies. So the IVUS using the intravascular ultrasound led to an increased number of stents in 13 out of 57 subjects. So overall, using the IVUS changed the treatment plan in 57 patients, which makes a big difference. This is our setup in a video hospital in Bahrain, and you can see beside the ultrasound conventional and the angiojet console, the powerful C-arm, there is always IVUS available, and we use it almost for all the cases of the interventions. I will just illustrate it on one of the cases we have done recently. You can see the patient admitted with a proximal DVT. This is the IVC ultrasound. He was put on oral anticoagulation in combination with Clexane, but he was not getting any better. He developed the shortness of breath. It was the CT venogram was done. As you can see, there is a proximal occlusion reaching the IVC with the segment of the floating thrombus in his IVC. The physicians taking care about him got scared in a private hospital, and they contacted us. The patient was transferred over the weekend, and we put him into the theater. You can see the IVUS available there. He was morphine dependent. Every 3 hourly he was not unable to walk. He was short of breath, and he was scared to death, because he was a clever engineer who read a lot about the life-threatening possibilities. So we gained the access through the tibial veins, ultrasound guided. What we found was a thrombosis from the femoral all the way to the IVC. We did the angiojet, thrombectomy, and 12 hours thrombolysis additionally with a great result. So this is the moment where in ATTRACT trial majority of the cases finished, unfortunately. But if you see the venography cannot just reveal the stenosis because the May-Turner is anterior-posterior compression. So that's why when we used the IVUS, it revealed almost occluded segment of the vein, which was stented. This is the IVUS post-stenting. You can see the waist of the balloon at the May-Turner point. So this is the significant stenosis, almost occlusion, and this is the result after the stenting. Because of the floating thrombus in the IVC, we also deployed the semi-deployed wall stent inserted transjugulary as a temporary IVC filter to prevent any embolization during the manipulation. And this is the patient after 12 hours post-procedure. So I put this image to see how fast and effective is the treatment. He was admitted in a condition as I mentioned, and in 12 hours after the treatment he was free and he was walking. He was discharged in 2 days on oral anticoagulation, and he is doing very well. So in conclusion, the IVUS is a mandatory tool in venous reconstructions. It's able to reveal the pathologies and structures otherwise invisible. It's even if you change the planes on venography, you cannot identify all the lesions. It's much superior. You have to use it in sizing. The dynamic, it doesn't matter. You can play with it. You can measure the circumferential diameters. You can measure the diameter itself, and it's essential to deal with the management of the complications as well. Thank you very much for your attention, and my warm regards to Egypt again, and I hope to see you soon in person again.